Well, with that image there, Mady, I see that you're going to give us a high-level overview of the topic.
Yes, John, let's talk about a few cases that have been referred to me. I want to share those cases with my colleagues. Basically, failing to plan is planning to fail. So there are some lessons that we can learn from those 4 cases that I'm willing to share. As you see here, I saw this patient when the implant, the area of 3/6, was not inside the mouth. And we actually requested the radiograph, the panoramic, and the radiograph taken at the time of the surgery, at the time of the restoration, and 2 years later. You see the implant in the area of 3/6 has continuously progressive bone loss, and this implant is not inside the patient's mouth any longer. Also, when we look at the panoramic, the initial diagnostic panoramic, we see a huge bone loss in the area of 3/7 in the forcation area, 4/6 forcation area. We see very significant bone loss on the mesial aspect of 2/7 with very ragged surface on the distal, indicating that there is tremendous amount of plaque and calculus has not been touched at all. The other case, this patient was referred to me for gingival recession in the area of 2/3, and from the time of initial consultation until I actually saw the patient for the surgery, in 4 weeks, we saw the sinus tract coming up on the buccal aspect of the implant in the area of 2/2. Again, implant the area of 2/2. Radiographically, it doesn't look like there is anything wrong with the implant. But as you see here on the gingival aspect, there is a sinus tract with presence of suppuration and pus coming out. The third case, we've discussed this before in a discussion with OISIS. The implant was placed, and at the second stage, 12 millimeter pocket has been developed 2 months after the second stage, and you see tremendous amount of distal bone loss in the area of implant 1/4.
So would you just point to that again there with your cursor and just highlight it?
Sure. This is the area of bone loss 2 months after insertion of the healing abutment or doing the second stage surgery. So this is tremendous amount of bone loss.
Perfect.
In the other case, this patient had the chief complaint of presence of a sinus tract here with the bad taste in mouth, and patient was complaining about presence of pus coming on and off. These 2 implants were placed 25 years ago, and we actually did the probing. We looked at the CT scan, and as you see here, there's no buccal plate at all. So these 4 cases will be addressed at the end of this conversation. But my point here is the paradigm has shifted. Back in 1988, when we were talking to patients, we were saying, Mrs. Jones, implants do not get cavities. They are great, and they don't get periodontal disease. But now we know that the implants, they don't get cavities, but they can get peri-implant diseases. And that would be something that should be communicated to the patients at the time of the initial consultation and also in recall examinations. As more number of implants are placed in general practice and in specialty practices, we are seeing more number of complications happening, not because only we place more number of implants, but also because we know more about the complications now. And as you see here, in terms of the prevalence of pre-implant disease, literature is very different. Like you can have a mucositis up to 90% of your implants, which is very significant. Or you can have peri-implant infection up to 43% of your implants or up to 56% of your patients. So the number of implants with sort of inflammation or infection is significantly high in practice. But it's very important to mention not all bone loss around implants are considered peri-implantitis. Peri-implantitis is considered a pathologic and bacterial infection. There are some other reasons that implants may get bone loss, such as bone remodeling around the implants, or biologic width establishment, or there are some other reasons like early implant failures. These are not considered peri-implantitis. Peri-implantitis means inflammatory reaction around the tissues of implant with subsequent progressive loss of supporting bone beyond the biological bone remodeling.
So the key thing here is it's a soft tissue condition, essentially. That's the genesis of it, right?
Actually, this slide shows what peri-implant diseases include. Peri-implant diseases are three major categories. It usually starts with peri-implant mucositis, meaning that it's like inflammatory lesion. It resides in the soft tissue surrounding a dental implant. The clinical presentation of this condition is usually bleeding on probing. We can say it's equivalent to gingivitis. Peri-implant mucositis incidence prevalence can be up to from 50% to 90%, depending on different studies. But the major issue is at this stage, we still do not have progressive bone loss around the implant. So the inflammation is limited to the soft tissue supporting the implant. As the disease or as the infection progresses, we are going to start seeing the inflammatory reaction extending to the bone around the implant. And at this point, you will get bone loss around your implants. The prevalence of marginal peri-implantitis or crestal peri-implantitis can be from 12% to 50% of implants, depending on different number of studies. The clinical presentation of peri-implantitis or marginal peri-implantitis is bleeding on probing, deep probing depth, and radiographic bone loss. So when you look at your implant and you see the bone loss beyond the physiologic remodeling that usually happens over the first 2-3 months after insertion of the implant, this is considered marginal peri-implantitis. There is another disease that it's rarely talked about, and that's considered apical peri-implantitis or retrograde peri-implantitis. And the prevalence is about 1.6 to 2.7%. And it's very similar to periapical chronic periodontitis. It's a symptomatic periapical lesion that normally develops shortly after insertion of the implant. And interestingly, the crestal bone remains intact, and the periapical bone around the implant is going to be lost. So here I provided some images. As you see on the top left, we can see there is bleeding on probing, but there is no significant probing depth. So in this implant, when we look at the radiograph, it doesn't show any significant bone loss, but we have the bleeding on probing. It means that we have the inflammation. And as you see, there is no loss of attachments, but inflammation exists. And this is defined as peri-implant mucositis. As opposed to here, we can see we have deep probing depth up to 9 millimeter. And radiographically, we can see the radiographic bone loss on the distal aspect of the implant, which has happened on the crestal aspect of this implant. This is considered marginal or crestal peri-implantitis. This image here shows the apical peri-implantitis or retrograde peri-implantitis. As you see here, the crestal bone remains intact and osseointegrated, but the apical bone is lost. There are so many reasons have been defined as the causes for this phenomena. And one of them has been extreme heat production at the time of osteotomy. So if you do not have enough irrigation, or if you insert your implant with extremely high torques, you may actually cause necrosis in the bone. And as a result, this bone may actually get necrotic and you see this bone loss. One of the other reasons have been indicated as presence of previous chronic periodontitis or granuloma or cysts in this area subsequent to having an infected or failed root canal treatment. Studies have shown if you have a tooth with chronic periapical periodontitis, there is a chance of 18 to 13% development of apical peri-implantitis in this site. The other thing is many studies have shown if you have failing root canal treatments or infected root canal systems in neighboring teeth, you have a chance of 25% development of retrograde peri-implantitis, which indicates how important it is to screen and monitor the neighboring teeth and also the implant site before the implant is inserted. Again, the top image also shows the peri-implant bone loss and also the crestal peri-implantitis.
So are they three separate conditions?
Exactly. There are different varieties of peri-implant diseases. So actually, peri-implant disease is not only one disease. Peri-implant diseases are different diseases like periodontitis, which are considered a group of diseases.
Right.
And peri-implant mucositis is reversible. So if we can catch this condition on time, we can reverse the condition and we can rescue the implant. Because at this point, we do not have the bone loss around the implant. The only clinical indication most of the time is bleeding on probing or presence of inflammation on gingiva. But once peri-implant mucositis proceeds to the peri-implantitis, then this phenomenon is going to be progressive and non-self-arresting. It's interesting, in periodontitis with teeth, majority of patients develop their attachment loss and bone loss in a very short period of time, and the disease most of the time might be self-arresting. As opposed to peri-implantitis, once the disease starts and the bone loss happens around the implants and the infection goes on, this will carry on until the implant comes off the mouth. So there is no self-arresting characteristic with peri-implantitis. Studies have shown peri-implantitis has very similar periopathogens, similar to what we have around periodontitis condition. And it's interesting that when you place implant inside patient's mouth, it only takes about 30 minutes from the time of insertion to have the bacteria inside the mouth colonizing around the implant. So imagine if you have a patient with active non-treated periodontitis,
yes,
the bacteria can easily float and travel through the saliva and come in and colonize your implant. So that's why you may actually see the correlation between a high incidence of peri-implantitis in people with a history of periodontitis or untreated history of periodontitis. So peri-implant diseases, specifically marginal peri-implantitis, has a gram-negative anaerobic motile flora, which is very similar to what we see around periodontitis.
Right.
And it's important to know what determines the microflora around the peri-implants is the bacteria inside the patient's mouth. So if you have a case with history of periodontitis, if you have a patient with periodontal disease, that type of bacteria can actually affect the implant as well. So if they are losing teeth because of the bone loss, because of the periodontal diseases, then there is a very high possibility that they lose the implants because of the same phenomena. This is actually a consensus report by 6 European workshop on periodontology back in 2008. They defined some risk indicators for clinicians to come up with a formula that if you have these conditions, you should warn your patient and you should be aware of higher incidences of peri-implant infection. So the first one is poor oral hygiene or biofilm. There is an odds ratio of 14 times higher rate of implant failure and infection. It actually makes sense. If patient is not able to take care of their teeth, obviously they are not able to take care of their implants either. The other thing is exposed threads. So if we have very minimal bone at the site of implant and the bone resorbs slowly and gradually, you will get the rough surface, very porous surface of implant gets exposed to the oral cavity and would be colonized with the bacteria. So this is a matter of chicken or egg. So when you look at the radiograph on around the implants and you see the bone loss, we should determine if the bone loss happened first because the bone was not great, or the bone has been lost because of the trauma at the time of the surgery, and as a result the threads are exposed and the bacteria are coming later, so they are latecomers, or the bacteria came first and they caused bone loss around the implant. So this is something that it's very difficult to know, but we know the exposed threads around the implants are a risk indicator for peri-implantitis. So if the bone is not great, augmentation has to be done, or slimmer or with smaller diameter of implant should be placed so we can preserve more amount of bone. The other thing I talked about is history of periodontal diseases. Studies have shown people with several pockets greater than 5 millimeters. They are actually, these 5 millimeter and higher pockets are working as the reservoirs for bacteria inside the mouth, and they can easily colonize implant surfaces, which is a risk factor for development of peri-implant infection. Smoking is a risk factor for periodontal disease as well. Poor diabetes. There are some studies about the alcohol, and also some studies have shown some people may develop more tendency to develop peri-implant infection because of their genetic traits. But these are all risk indicators. They don't mean that these are risk factors, because we haven't actually have a sort of cause-effect relation between these elements. But they are important to be understood and taken into consideration when we're planning for implant dentistry. I would like to draw your attention to this slide, because I think these are more and more common things that are happening, and these are things that are preventable in clinical practice, like cementation. Cementation is a huge problem now because people, dentists, tend to cement the implant crowns very similar way that they cement crowns over teeth, but implants are not teeth. We know teeth have Sharpie's fibers, they have transeptal fibers that are perpendicular to the root surface, and they prevent majority of the foreign objects from going further apical. As opposed to implants do not have any Sharpie's fibers, do not have any transeptal fibers, and if you put lots of cements and you push your cement down, this will go until it gets to the crest of the bone. This area never gets cleaned, and this works as a permanent calculus with subsequent bone loss. And also the implant position is very important. These days, we should actually try to use the custom-made CAD/CAM abutments. By having patient custom-made CAD/CAM abutments, we can design the margins of our implant crown 0.5 millimeter apical to the gingival margin. As opposed to using the stock abutments, you have to go very deep in some occasions, and this would be the problem. As you see, we have cements, and obviously subsequent bone loss, which will cause this implant to fail for sure. The other thing is about the prosthetic components. I would like to actually talk about how passive prosthesis is important, because if the prosthesis components are not fit over the implant fixture, there will be always a place for bacteria to hide in, and as a result of biting, this bacteria will pump in and pump out inside the mouth, and the screw hole would be a very ideal place for bacteria to colonize. Occlusal overload has been shown could be a contributing risk factor to bone loss, but it's important to know in the environment that we don't have bacteria, occlusal trauma may not be able to cause peri-implantitis. I talked about the implant surface. The other thing, as a periodontist, I see many times is lack of keratinized attached gingiva around implants. And this has been shown significantly in many studies that will cause or will be related to more bone loss around the implants. So as you see here on the image on the left side, we have almost zero attached gingiva with subsequent tremendous amount of bone loss and plaque. And as you see here, it would be extremely difficult for patient to maintain a good hygiene here because the threads are exposed. And there is no defense against the bacteria. The gum, the mucosa is not able to provide any seal around the implant. As on the right side, you see we have a very thick band of keratinized attached gingiva, which provides a good defense and seal around the implant, and has been shown significantly to improve the oral hygiene and plaque score, and subsequently less bacteria around the implants. It's a very minor periodontal procedure, but increases the longevity and health of implants, and it would be ideally done before the implant is inserted, because you can do this gingival grafting over the bone. The bone is a vital tissue. The graft will be very successful, as opposed to trying to put your gingival graft here over a vascular titanium surface. Would be very challenging and unpredictable to provide a good seal at this point. This is a case that I've done. So as you see here on the posterior area of the mandible, we did not have enough attached gingiva. So this is whole from a gingival graft from the palate. And you can see some rogays here as well, because the area was extensive and I had to go slightly more anterior, and you see the rogay. But we managed to provide a very good keratinized attached gingiva here. So when the implants are inserted, I am very confident that this implant will be protected by adequate keratinized attached gingiva on the lingual and buccal aspect. As opposed to if we don't do this procedure, then we end up having implants encircled by mucosa. And it's interesting because in some situations you can actually pull the cheek away and you see the gingiva exactly. So actually it separates itself from the titanium. So you can imagine how bad that pouch could be, and how bacteria can actually go in and hide and eventually cause your implant to fail.
Sure.
Micro leakage. We have this micro leakage issue everywhere in dentistry. Also here, we discussed this case in my previous discussion with OISs, that when we don't have fit components, like in this case, a non-fit healing abutment or gingival former was inserted inside the implant, and as a result of having a big screw hole not being sealed, the bacteria could hide here. And over time, they pump in and pump out. This area cannot be cleaned by patients, cannot be cleaned by hygienists. And as a result of presence of this bacteria, you may get this amount of significant bone loss with subsequent implant loss. So it's extremely important the components are fit, and we take radiographs to make sure they are doing okay. The rough surface, I talked about it. If you have poor bone quality or poor bone thickness, this bone will gradually resorb and you end up with exposed threads. And now we have a very good area for bacteria to colonize and subsequently cause more bone loss. The micro gaps are important. On the left side, you see the authentic components from one of the implant companies, and the other two are the knockoffs, the copycats. And when you look at those microscopic images, you see, although they are claimed that they fit, and clinically you cannot actually distinguish the fit between the authentic and the knockoffs, but you see the difference between these three. So this is the original components, and these are the knockoffs, and you see the gap here. So these gaps are fully filled with bacteria, and over time they will jeopardize the longevity of your implant. So it's extremely important to communicate with your lab technician that we should only use original, authentic healing abutments, abutment screws, final abutments from the same company, although they may come up a little bit more expensive. But they prevent these problems like peri-implantitis as well. I talked about the inflammatory reaction around the implants versus teeth. It's interesting that the inflammatory reaction around implants are significantly larger. And in histopathology examinations, we have noticed this inflammatory reaction can go up to the bone level, to the crestal bone level, which is very, very unlikely to happen around teeth. So the inflammatory reaction cannot be very close to the crestal bone in periodontitis, but in periimplantitis, because there is no Sharpie's fibers, there is no transeptal vertical fibers, these inflammatory reaction can go significantly close to the crestal bone, and as a result, you will get bone loss.
Right.
So that's very important. This shows the difference between implant and tooth. You see the tooth root surface, the Sharpie's fibers, the transeptal fibers, Sharpie fibers, transeptal fibers. These are all protecting this bone, as opposed to the implant. They are all parallel, and that's why the inflammatory reaction can go beyond the crestal bone. And as I mentioned, it's very progressive and it's not self-arresting. It just shows a difference in terms of the vascularity of the tissues around the implants versus teeth. We know the tissues around implants are less vascular and they are more collagenous. And as a result, the healing capacity or the ability of the tissues to regenerate is significantly lower. The response to treatment might not be ideal. And also I spoke about the fibers attachments and even the different types of fibers around the implants. So again, as you see here around the teeth, we have different variety of fibers that protect the tooth and protect the crestal bone from biofilm and bacteria inside the mouth, which we do not have it with that extension around the implants. Again, peri-implant bone loss increases with time. This is no-brainer. It will not stop and it will go on until the implant will fail. As a clinician, what we have in terms of diagnosis of peri-implant diseases, the first thing is implant mobility. If you have a mobile implant, we have to first identify if this mobility comes from the crown of the implant or the implant fixture. There are many occasions that the mobility is from screw loosening. So we have to make sure the implant crown has not been loosened. And if the implant crown is loosened, and we actually need to remove the implant first and do the torque test on your implant to make sure the osseointegration is preserved. If it's not, then a mobile implant fixture is considered failure and the implant has to be removed. Probing depth is very important around the implants, but we need to have a baseline probings around the implants at the time of crown insertion. Because if your implant is placed significantly more apical or the tissue thickness is significantly more than, in some people it's very thick, then you will end up with higher probing depth. So I would say the probing depth around the implants should be considered with some cautions, and also we should have a baseline probing depth at the time of the crown insertion, and we monitor these numbers over time. Bleeding on probing, if the bleeding on probing is not present, it shows the health, but presence of bleeding on probing shows inflammation. Presence of suppuration, if we see suppuration coming out, it's not a good thing. It's something that we need to do intervention. Radiographic evaluation as well to see if there is any bone loss or if there is any progressive bone loss relative to the radiographs that we have at the baseline. So now we know how we can prevent this from happening by preventing those things like cements, having good keratinized tissue, having passive fit structure, preventing the micro leakage by using the authentic components, checking the occlusion. But there are some occasions that as a clinician we have to go in and try to either rescue the implant or do something for the implant, because as I mentioned, this is not going to stop. So the goal for peri-implant disease treatment is to do surface decontamination and detoxification. Implant is different from tooth because you can have root planning and scaling around the tooth, and you can end up with pretty smooth and glassy surface around your implant, around your teeth, as opposed to implants are extremely porous, and many companies are going toward medium rough surface implants to provide better bone to implant contact. And as a result, when you get exposed threads and peri-implantitis, it's almost impossible to get rid of the biofilm on your implant surface. But the goal is to reduce the bacterial load by dilution to the level that will allow healing, and that's the goal. And it's very difficult by mechanical means alone. That my focus in this presentation is to raise awareness around practitioners that are doing implant dentistry or having patients with implants in their mouth. Because as I mentioned, if we can catch these problems at the level of peri-implant mucositis, we can prevent the problems down the road. Peri-implant mucositis can be non-surgically managed by having a proper debridement around the implants with the specific tools dedicated for implants. But when we go to the peri-implantitis phase, there is no definitive, predictable, non-surgical treatment, and the flap surgery still is the most valid treatment modality to deal with peri-implantitis. As you see here, we have different variety of tools and techniques to clean around the implants, like curettes, ultrasonics, lasers, air powders, mechanical brush, and with some chemotherapeutic agents like chlorhexidine, citric acid, tetracycline hydrochloride, hydrogen peroxide, photodynamic therapy, and also sterilizing the implant prosthetic components. But still, we do not have the best technique to decontaminate and detoxify around the implants.
In your practice, what tend to be the top treatment choices there?
In my practice, for cases like peri-implant mucositis, what I do is non-surgical treatment. And what we do, we use a variety of hand instruments like curettes, titanium curettes, because we should not use any stainless steel curettes that we use around teeth, around implants. We will cause more scratches and more problems around the implants. So titanium curettes or carbon curettes. I'm not a big fan of plastic curettes because, in my opinion, they don't do that much in terms of removing the tenacious plaque. Also, I introduced the air powder abrasive ProfiJet. There are some products like Air PerioFlow from Hufridi, which has a very small nozzle, and the nozzle can go up to 5 millimeters below the gingival margin, and it sprays air, water, and glycine powder, which can disrupt the biofilm, based on many studies, more effectively than ultrasonics and hand instruments. We also do some cases photodynamic therapy, like PerioWave, which is a sort of a solution that would be activated by low energy laser, which has been shown produces some radicals to kill the bacteria. But as I said, we always want to combine whatever we have, because we know none of these techniques or solutions or materials are sufficient on their own. It's important to know the many questions that we get from our referring dentists. When you see bone loss around your implant, can you confidently say you will get re-osseointegration around your implant? So you may open up the flap surgery, you may do bone grafting, but are you confident that that bone graft will be attaching to your implant surface? Well, this has been studied several times by different authors, different researchers. There are some animal studies that have shown you can get up to 80% of your cases re-osseointegration, but we cannot generalize the conclusion of this study to every implant surface, every different conditions. I would say we don't know. It's very controversial, and there is no conclusive evidence showing that you will get re-osseointegration.
You wouldn't bet the family farm on it, eh?
Exactly. So it's basically, there are different protocols that have come up in clinical practice that might be useful. And I show you this one, which is by Lang in 2004. It's called cumulative interceptive supported therapy. It's very simple and it's very useful for practitioners, hygienists, when to diagnose the problem, how to manage the problem, and when to refer. So basically, if you have probing depth less than 3 millimeter or equal to 3 millimeter, and there is no probing, there is no bleeding on probing, you don't need any treatments. So your implant is in the health condition. But if you have probing depth less than 3 millimeter, but you have bleeding on probing positive, you have peri-implant mucositis. So as I said, 90% of your implants might be in this stage. They do not have deep probings, but they have bleeding on probing. And we have to do treatment here. Mechanical debridement, air abrasive polishing, it should be considered. And then based on this protocol, if you have probing of 4 to 5, you need to put the patient on antiseptic cleansing, like chlorhexidine mouthwash for 2 weeks, following the mechanical debridement. So you will add up your treatment from the previous stage as well. But if your probing depth goes beyond 5 millimeter, you must take radiograph to evaluate the peri-implant bone level. So if you don't have bone loss or no changes from your baseline radiograph, basically you just need to do mechanical debridement, antiseptic cleansing, and some people, they may consider systemic or local antibiotic therapy. And I will show you in the cases that I've managed. But also there are some cases that you may develop bone loss, but the bone loss is less than 2 millimeter from the baseline. So you add these type of systemic or local antibiotics. But when you have bone loss greater than 2 millimeter, then you need to proceed with flap surgery. So if you see your bone level has changed 2 millimeter or more from your baseline radiograph, this means that you are actually experiencing peri-implantitis. And this is the case that needs sort of treatment with periodontal flap surgery.
Can I ask you a quick question about the previous slide there? Just go back a second. Just the less serious types of cases where there's the mechanical debridement and the polishing and antiseptic cleaning, is that a one-off, or does it have to be repeated, and or is there a sort of a cycle, or is there an interval?
That's a very good question. It's like when we insert the implant inside patient's mouth, we should tell them this implant needs annual assessment, and they need to get a sort of a protocol for maintenance. Depending on patient's oral hygiene, patient's susceptibility to periodontal disease, and so many other factors, then we have to customize a maintenance regimen for that patient. So as you mentioned, mechanical debridement around the implant should be done. This protocol, when it's done, the patient comes back in 6 to 8 weeks for assessment to see how effective we were in terms of treatment. And if the problem has been resolved, then you put your patient on a recall examination. But if the problem does not resolve, then we have to either refer the patient for further investigation and assessment, or we have to increase the number of the intervals for mechanical debridement and antiseptic cleansing. My point is we should not be afraid of touching implants, because in general practice, specifically those practitioners that refer patients for implant surgery or crown, or the hygienists may be afraid of touching implants because they may actually think that they may destroy the implant by doing proper maintenance, proper cleaning. My suggestion is, as long as we use the proper instruments that we should have in our practice, we should not be shy of going around the implants and deal with the problem at the very earliest stage.
But clearly you have to have the right instruments and you have to know how to use them.
Exactly. So that's very, very important. And we have to look at the patient's mouth, because sometimes the implants may not be distinguishable from natural teeth. So We want to check our records, radiographs to make sure before we use the stainless steel curettes or regular ultrasonic tips.
Right.
We want to identify which structures are implants, which structures are implants. So in my practice, I have a sort of a protocol that I use in order to deal with peri-implant problems. And I start from here. The first thing I will look at is mobility. If I see mobility around the implant, I will remove the implant. And if that mobility is related to the fixture. If the implant is not mobile, I will look at the probing depth. And if the probing depth is less than 5 millimeter, I will look at the BOP. If the BOP or suppuration is present, but my probing is less than 5, I'm dealing with mucositis. So the treatment is non-surgical treatment and antimicrobial remedies or therapies. But if I do not have any bleeding and probings are less than 5, obviously we have a healthy implant. But if your probing depth is 6-7 millimeter within this range, then you will look at your radiographic bone level. So you certainly need to get a radiograph when you have an implant with 6-7 millimeter probing. And if you see you have less than 2 millimeter bone level changes relative to your baselines, then this would be considered mucositis. And again, you start with non-surgical treatment and antimicrobial therapy and further follow-ups with the patient. If you see more than 2 millimeter bone loss, or if you notice that this bone loss is progressive, then open flap debridement and the implant detoxification, decontamination is important. In terms of the surgical management, some people, they may say, okay, we do flap surgery and then we do bone grafting, but we cannot do bone grafting in all cases around peri-implantitis. We have to look at the radiographic bone topography or clinical bone topography. If you have a sort of a well-shaped, funnel-shaped defect or sort of a suturization around your implants, the apical portion of this defect might be amenable for regenerative therapy. But the coronal portion may not be, because you will not be able to regenerate bone in 360 degrees. You may not be able to do that. It's very, very unpredictable. So you may end up doing some implantoplasty. So you decide to apically position your flap, so expose more of your implant surface with the expense of compromising aesthetics, which is manageable in posterior area, but you will have healthy probing depth around your implants and you make sure there is no reservoirs for bacteria. Or if you see the defect is amenable for regeneration, you can consider regenerative therapy during this procedure. I'm very focused on keratinized attached gingiva because in my own practice, I see more number of problematic implants with inadequate keratinized attached gingiva. So if that's not sufficient, we will produce that around the implants before or after doing the peri-implant surgery, depending on how you manage your protocol. If your implant has greater than 8 millimeter probing depth and you see more than 50% radiographic bone level loss, then this case is a very significant peri-implantitis, and then you have to choose between two options. One would be explantation, remove the implant, or and also obviously grafting and starting again from scratch, or you consider rescuing the implant with much significantly less chance of success because you've lost more than 50% of your implant bone level. The most important thing here, in my opinion, is this statement from Dr. Stuart Forum is while there is no evidence suggesting which is the most effective treatment for peri-implant disease, that doesn't mean that currently used treatments don't work. So that's very important. We cannot say predictably we can treat all implant cases because there are so many factors working like implant surface, patient's immune reaction, the protocol of the surgery, but we know there are some cases that we can rescue the implant. So now I want to talk about the case that I showed you. This was the second case that I showed you. This patient was referred originally for gingival recession in the area of 2-3. We had 6 millimeter gingival recession. And from the initial visit to the time that we were preparing for the surgery for the connective tissue grafting, patient called our office and patient was complaining about a gum boil. So patient came in, I took this radiograph and you see the sinus tract and this operation is present. When I poke it, the pus is coming out. We took a radiograph here and it's very evident in this radiograph, the implant has been inserted too deep. One of the problems with very deep implant insertion is you will have a very deep pocket to start with. And we know deep pockets means bacteria not being cleaned. It's very difficult for patient to clean here. And as a result, you will get periopathogens, red complex, and this happens. So even the implant position can play a role in your implant fate, because here the implant was placed too deep, the pockets were deep, and this is right after the flap surgery. As you see here, we have 2 threads exposed with very significant suturization around this implant. In my practice, we do the concentrated growth factors. We do a little bit venipuncture to centrifuge, to do the centrifuge of the venous blood of the patient. And what it does, it separates your venous blood to different 3 different categories. And this area is the area with platelet-rich fibrin, concentrated growth factors like PDGFE, VEGF, all those good growth factors that help with soft tissue regeneration and revascularization of the wound. And these are the PRF membranes, and we use the sticky bone protocol, the bone after detoxification as much as we can, decontamination with hand curettes, ultrasonic and airflow abrasion, then the GBR is done. In this case, I also used localized antibiotics. Aristin is minocycline hydrochloride, 1 milligram is it's with high concentration, and it has been shown in some studies that it can be more effective when it's added to the scaling and root planning relative to scaling root planning alone. So many studies in periodontitis have shown adding this locally administered antibiotic can have a better outcome relative to scaling root planning. And this is the unit that I showed you. It's actually injects high intensity air and water and powder to disrupt the biofilm below the gingival margin. So we saw the patient, and this case, this is about 4 weeks after the surgery. So as you see here, I also did the connective tissue grafting at the same surgery to achieve the root coverage. So I assume that this surgery has gone very successful because we managed the infection. The gingival margin looks healthy. There is no sinus tract, and we got a very good root coverage here. And as you see here, because of the resolution of inflammation, we got a slight amount of gingival margin recession around the implant. This should have been communicated and has been communicated with the patient. It's important every time we do a flap surgery around implants in particular, we warn the patient there is a risk of gingival recession around the implant and neighboring teeth.
Do you expect that papilla to get any better looking over time?
I'm expecting, I saw this patient actually 4 weeks after this for supportive periodontal therapy, and this actually has improved significantly. We are expecting the papilla come back again within the first year, but this has been very clearly communicated with the patient that the final position of the gingival margin around the implant might be slightly more apical relative to where we started from. And as a result, there might be a need for crown replacement and so on and so forth. But peri-implant diseases are a health concern because we are dealing with deep pockets, bacteria, And we know many studies have shown significant association between bacteria in the oral cavity with systemic diseases. I discussed this case before in the previous discussion we had in this platform. I don't want to actually spend more time. This implant, as a result of poor fitting, healing abutment, we got distal bone loss. Unfortunately, this implant did not take, or the integration failed. We had to remove the implant and do the GBR and go later on with a new implant, a new procedure. This case is extremely important because when you look at this, you see a very tiny point here, red point, and when I actually put my probe in, I can feel the metal sensation. So it shows there is no buccal plate there, and these two implants were placed 25 years ago. And back then, I believe the concept was to put the implant exactly where the tooth was. But now we know that implants are going to be inserted more palatally to preserve the gap between the implant and the crestal bone and on the buccal plate to actually be able to get some bone regeneration in the gap. So these two implants, again, we raise the flap, and this is what we see on periodontal flap surgery. As you see, there is absolutely no buccal plate in this area. And well, I wasn't very confident to do bone grafting around these implants because I didn't know the implant surface. I didn't know if this implant surface is amenable for regeneration. And as you see here, the bone loss goes all the way apical to the implant surface. So what we did with piezo surgery, ultrasonic, I made the trough and tried to remove these implants. This area is extremely important to be taken care of surgically because the bone is very thin. The premaxilla is very fragile, and you want to minimize any forces. So it took me about 45 minutes to 50 minutes to remove these two implant fixtures because they were osseintegrated from the palatal and mesial aspects and distal aspects. So you have to go and make a trough with your piezoelectric surgery. And then 6 weeks after, we raise the flap, and you see a huge bone deficiency on the buccal aspect. So this bone needs augmentation. So we did the guided bone regeneration with the pre-osteal scoring to be able to provide primary closure. This is my collagen membrane over the allograft. And as you see here, this is 6 months after, and you see the difference here. This is before and this is after. And now we have adequate bone thickness to be able to start again for insertion of two implants. The bone is vital, it's bleeding, and it's showing that this is good quality bone. My surgical stents and my guided drills to insert two implants. The implants have been placed on restoratively driven way, and certainly my colleague has placed these two implant crowns. We established the health around these two implants by providing adequate bone and starting again. As I said, peri-implant diseases are not always manageable by rescuing the implants. There are some cases it would be significantly better to the patient's health if we take them out and we start again. This is something that I want to bring it up because it has been shown. This is the way that I communicate with my patients about the pockets and periodontal disease in my practice. Because when I talk about deep pockets, bleeding, people, they don't have pain. Some people, they say, Dr. Norouzi, I don't have any pain. There is no discomfort. Why I should be worried about deep pockets? Why I should be worried about bleeding? And this study is very, very important. And I have this print in my practice, and I show them in a patient with multiple 5-6 millimeter probing depth when you have a generalized moderate periodontitis. If you calculate all those tiny bleeding areas of your pockets, it can be as big as the surface of palm of hand. And I always tell my patients, if you have a wound as big as palm of your hand, are you going around with no bandages or no seeking treatments. This is exactly what's happening, because many people, they don't know how pockets can affect their general health. And I believe this is a very good communication tool for our patients to understand how extensive these bleeding on probing areas with these tiny ulcers can be. Thank you very much, John. Thanks for having me. I would be glad to answer any questions. Please feel free to call me or email me if you have any questions about the cases that I've shown and also the contents of this presentation.
Mehdi, I want to thank you for your generosity in sharing your knowledge like this, and for your time. And certainly, you're so generous to invite colleagues to communicate questions to. And perhaps we can capture you answering some of those questions on here next time.
Absolutely. I would be pleased to do that.